Ramesh Ganapathy is going to talk to us a bit about the experience. He's a senior clinician, I think was clinical director, and is really well placed to have that senior overview of how we should be implementing interventions in the NHS. Works at Epsom and St Helier, and delighted you can share perhaps your experience with the logistics and economics of implementing screening in the NHS, which is quite an important point. Ramesh, I have to rush off to see a patient, unfortunately, but I will listen to your talk later. And Kate Harding's very kindly going to take questions with you at the end. So thank you for coming.
Right, good morning, everyone, and thank you to Marcus and team for this invite. This is a much more practical demonstration of what happens when you have evidence and how to implement it from a general hospital setting. So we're going to give you our experience of implementing the APRE trial as it was intended over a period of 3 years. So there's no declaration. I don't have any affiliations to any organization. So who we are is a NHS trust in South London. Now we're part of the George's and Epsom and St Helier group as well. It traverses 2 maternity units with birth rate varying between 3.7 to 4,000 per year. It's a multi-ethnic population serving with different economic, socioeconomic deprivation indexes from the north to the south. What we were doing before was routine 20-week uterine Dopplers for the last 8 years. And since pre-COVID, we just started doing a 36-week routine scan. So that was the background with which we came to this. And obviously, it's not about an individual, it's about a team. So this is all the sonographers, the midwives who agreed to have their photographs taken for this presentation. And the background was that we were following what was always said, follow antenatal care guidelines for NICE, and then the hypertension in pregnancy diagnosis and management guideline. And we knew that this was what was being done across the country. And the current practice was pretty much high-risk women, offer them aspirin and offer them anywhere between 75 to 150 milligrams of aspirin. And we did what every other hospital was doing. But we knew what the detection rates were in terms of just using maternal factors. And this was highlighted by the Fetal Medicine Foundation. And we felt that it was better than nothing, but it's still the detection rates were very low for the early onset preeclampsia. At term, we know that none of these things work as well. So we felt that we need to do something different rather than doing the same thing every year and trying to expect a different outcome for our women. So we said we'll first audit what happens with our preeclampsia in our population. And we knew what our rates were, which is pretty much reflective of what happens across the country of a very early onset preeclampsia of 0.23 and 0.54. For our population, worked out around 20 to 22 cases, which have a disproportionate impact on experiences in pregnancy and outcomes for mothers and babies. So we did the next thing because we had to convince people that we were going to go against the flow with just taking maternal history. So we actually calculated how much each case costs us from a neonatal cost. And this was based on the tariffs that were published by the NHS. And we looked at the cost for each delivery and the cost for the mothers in relation to HDU or ITU care or blood transfusions or emergency sections. So we had a lot of options, and I understand that lots of people have implemented various forms of preeclampsia screening, and it has been sort of a smorgasbord of choices, just to use maternal history or check her blood pressure, or if you can do the uterine Dopplers as well, or just take the blood pressure and do PLGF or do all of it. But the original trial had suggested that you do all 3 with the maternal factors. And we decided that that was the published data, which was come from a randomized trial from 2017. And that was robust data. So if you're going to implement it, we implement it as it was intended. So that was our plan from the start. And obviously, people are aware of the APRE trial. It's a busy slide. I'm not going to repeat everything that's there. But long and short of it, they screened 26,000 women, and if the preeclampsia risk was greater than 1 in 100, women were randomized to 150 milligrams of aspirin or a placebo, and showed that there was a reduction in incidence of early onset preeclampsia. Since then, lots of people have published. The validation of this study occurred. Some of them were in the UK, but none of them were in the UK were using the APRE trial as intended originally. But people outside of UK have done economic analysis and also implemented the study as intended, and found that their results were similar to what the APRE trial achieved. So we had a bit more confidence that we were going down the right path. So what we felt that are people not doing this because of cost, apprehensions about ability to deliver this outside of a research setting in the routine NHS care. Will women accept it? Or should we just stick with what NICE mandates? Or are we waiting for the RCOG to green light that this is the way to go? And does it matter if we choose parts of the ASPRE, or do we wait for another trial that looks for this trial to implement, whether we can implement it? Before we embarked on this, we said we need to understand the rationale by ourselves and by the team members who will be delivering the screening. And this involves midwives, healthcare assistants, sonographers. We had to educate everyone that we are going down this. The Maternity Voices partnership had to be we had to explain why we wanted to do this. We were fortunate that we didn't have to embark on training for Dopplers routinely, but we had to just do a time analysis of how long it would take, because we were going to implement this at the routine nuchal screening. We did a workflow for screening and saying how much time will this add, and does it impact on patient care? Some smaller things which were equally important were workflow for prescriptions and follow-up, and we had to prospectively audit every outcome that we had. So what we did was we did standard PowerPoint-based testing. Fortunately, post-COVID, everyone was very happy to have Teams-based teaching, so we reached a wider audience. Recorded talks, people could see it at their own time. But then everyone who was going to be delivering nuchal screening, 99% of whom were sonographers, did the pre-eclampsia module be available on the FMF website. And we also play, because we had an electronic patient record called Badgernet. We put links for all those resources on our Trust intranet and also on our electronic patient records. So we did training for these things. We had to ensure that we had on our fetal medicine database the ability to look at inputting all the history, because it's slightly different to just screening for trisomy 21, 13, or 18. We had to look at, they had to click the box about calculation of risk, and then referring these women for discussion about aspirin and midwives' capacity to deliver in a timely fashion counseling. PLGF, I think this audience does not need explanation about what PLGF is. It's primarily a growth factor produced by the placenta. It's been shown that it can be used in terms of assessment for risk of developing preeclampsia later, or assessment of acute presentation of in women who are suspected to have preeclampsia. But PLGF was not routinely available. So it was, the lab said, we do it on a research setting, but we have not delivered it as routine for all mothers and a capacity of trying to deliver 4,000 samples a year. So we had to look at cost per test, which was the blood test that was going to be taken at the 11 to 13 week scan for beta-HG and PAPE. It could be processed at the same time. We had to go down a business plan route for 4,000 tests per year. We also had to explain that we are going to have extra scans for these women, and how much will it cost? Cost of aspirin, we might say it's cheap as chips, but it is a cost to be calculated based on the screen positivity you will have in your population. So all this was done in advance. We created an information leaflet for the women, and so they would understand why they're going down this route if they were to be screen positive. And screening. So we had to get all the mothers to have their blood pressure taken in both arms, which was not done routinely. Then we had to ensure the healthcare assistants did it appropriately and recorded that on the electronic patient record, so sonographers were not struggling at the point of entry. And we checked the uterine artery pressures were being taken and getting the results on time. But fortunately, because we combined it with the beta-HCG and PAPE, the results were the same thing as sonographers had to enter one additional test, and they were happy with that. And then we had to we found that we could line up all the ducts and get this going. Simple things like showing how to take the blood pressure properly, how to take your blood test, take your uterine arteries. So these were posters put up so as an aid memo for people. And we kept it very simple. We said, if you're high risk for preeclampsia, you'll be offered aspirin and we'll continue your risk assessment for PE. Anyway, we did not want to change a lot in the pathway. So women registered at reception, healthcare assistant took her blood pressure, documents were recorded, and we had to align all of this so we got a risk calculation that was accurate for the mother. And in addition, we had to ensure that they had their scans booked at 24 weekly apart from 24 weeks. That was our policy. Some things that were happening in the background was to check on workload issues in the initial months to ensure that we are not missing women, because we're going to offer it as a routine screening for all mothers. This is outside of a clinical trial. So if you're offering it, everyone has to have access to it and understand why they're receiving it. And then we had time flow assessments done. The divisional management team signed off on all of this. And sonographers independently had their meetings, and they also sort of gave us a green signal to go ahead. We had to change our guideline. And what did we find? First thing we found was that we had to change our norms after a few months, because the PLGF norms that you have published are not reflective of the population you might serve. So we actually had to move our norms. Then this was the paper that was published by Edward, who was our research fellow, in ensuring that we were getting things right. We did a patient survey and we said, do women find this screening acceptable? Because what is one thing to hear that women want to be given the option of screening versus how it occurs in real world. Except for 3 women who declined all forms of screening, everyone accepted preeclampsia screening. We never had issues with that. And we found that all the information was sufficient. This was taken in initial parts because at that point we were concerned that do women understand what information is being delivered, and is being delivered in a format and in a way that is acceptable. And majority said yes. And all of them agreed to take aspirin. We didn't check on compliance, but we felt that they had accepted it. And obviously, you might forget in a day or two, but most of them said yes, they were continuing to take it because we were seeing them every 4 weeks for scans. The other thing was that it's a time commitment to have 4 extra scans, and if in busy worlds and trying to find parking in hospital parks, car parks is difficult, but they all accepted coming for extra scans. Most of them are very satisfied with the process. And this is reflective of our population, which the vast majority are between the ages of 30 and 34. And the next lot is between the ages of 35 and 39. And ethnicity, this is almost a direct reflection of our population. So the survey was reflective of that. And educational qualifications, vast majority were had university degrees. So once we started screening, we found that we had screen positive rate of 7.8%. But if we had just stuck with what we were doing before, we would have had 11% screen positive rate. So this is what we found. We found that if we just, this is based on if you had just used NICE-based screening, in early preeclampsia, we only have identified 16 of them. And with the current screening, we found 83%. And with the ones of less than 37 weeks of preeclampsia, that was 28% if we had just used maternal history, and 78% if we had used, which we used the FMF-based, APRE-based screening. But as is reflective of other things, for late onset preeclampsia, as everyone's aware, it's not that great. So, sorry, 1 second. So numbers screened were around 10,000. We analyzed the outcome of 7,500. The subsequent 3,500 is we're doing it right now. We found a reduction in preeclampsia. We demonstrated a savings of 172,000 with maternal and neonatal costs, and we're trying to do a long-term quality qualification calculations for reduction in preterm birth. So this is how we achieved. We looked at the cost. This was the cost of maternity care prior to screening and after screening, and that was the difference. A comparison of neonatal costs, which was related to the number of babies that were born iatrogenic preterm births, and you can see the drop there. So in our experience, preeclampsia screening at 11 to 14 weeks is superior. It's deliverable. It's cost effective in a socialized healthcare system like the NHS, and it reduces the incidence of the condition in high risk populations. And thank you.
Ramesh, thank you very much. That was a fantastic presentation and really good to hear how research can be implemented in a DGH. Because we often hear about how we can do the research or how things are done in the teaching hospitals. So to hear your way of doing it and your considered approach to all the different aspects of it was fantastic. Did I gather correctly that your incidence of early onset preeclampsia went down from 20 a year to about 12? Is that correct?
Correct, it is.
So that's fantastic, and is something I think that everyone should take away as a marker as to whether or not we can consider introducing this screening and implementation. So it's not just the screening, but it's the implementation.